My name is Brandon Kolk. I'm a Black Forest Soaring Society CFIG out of Colorado. Um, this webinar is tailored for soaring pilots, but it is 100% relevant for all pilots with and without a propulsion unit in front of them or to the sides of them. Please type your questions into the Q&A at the bottom of the screen and we'll answer directly via the chat, or if it's extremely relevant for what's going on exactly at that time, I will ask them live to Dr. Quay Snyder. Speaking of which, Dr. Quay Snyder will be presenting this evening. I've had the pleasure of knowing Dr. Snyder for about 8 years as a member of the Black Forest Soaring Society in Colorado. He's an accomplished glider pilot, CFIG, DPE, and a great friend. I could do an intro for about 60 minutes on this, but I only have about 1.5 minutes left. So let me give you a brief outline of some of Dr. Snyder's accomplishments. He is the president and CEO of Virtual Flight Surgeons, an aviation medical advisory service. He holds board certifications in aerospace medicine, addiction medicine, family practice, and occupational medicine. He travels the globe presenting his craft. He's graduated from the Air Force Academy, served in the Colorado Air National Guard as a flight surgeon for 25 years, board of director on the International Academy of Aviation and Space Medicine. He's a Gold SEAL, CFIG since 1975, a DPE since 1998, an FAA Safety Team representative since 2003, an SAA America's World Distance Award winner for 40,000 kilometers, which is the Earth's circumference, and solo cross-country flight in his own glider. Last but very not least, he runs triathlons and is qualified for the International Triathlon Union's World Championships representing Team USA. So let me tell you and hear me loud and clear, you're about to hear and listen to the leading aviation medical expert on this planet. Take notes, ask questions in the Q&A, and absorb as much as you can in the next 2 hours. So ladies and gentlemen, without further ado, I present to you Dr. Quay Snyder.
Thank you very much, Brendan. I appreciate it. That's a very generous introduction here. I'm going to share my screen, and if someone would confirm that you're seeing the full screen here. Let's see.
It looks good, Quay.
It looks good? Okay, well, thank you very much. And welcome to everyone who's on here. I appreciate your passion for safety and for flying. And what I'd like to do is talk about some of the physiologic strategies for cross-country soaring, but this is relevant to any pilot and was relevant actually back when I was in the Air Force. So this is a recreation of many presentations that I've given talking about physiology. Picture of me enjoying my flying, but let's talk about what we're going to talk about today. I'm going to go through the I'm Safe checklist, and then we'll talk about nutrition, hydration, elimination, vision, hypoxia, fatigue, and comfort. And then we'll have questions, which are questions for Quay as we go with them. But as Brandon said, please feel free to ask any question during the talk so that if it's particularly relevant at that time, I'll be happy to address that question. So what's our role here? Our role is to keep aviation safe, right? Keep ourselves alive. These people may be pushing the limits a little bit, but apparently they made it back. So let's talk about I'm safe. And legal is not always safe. Unsafe is not always legal. So let's distinguish between those. So aeronautical decision-making, and I will say in the context of today's talk, aeromedical decision-making is required before every flight. And if you're doing a true honest assessment, your assessment may change about your fitness during that minimal period of time that you're in the air. Also, a lot of people don't get extensive training in the physiology, and there are few readily available resources for people. Many people who have an aviation medical examiner are reluctant to go to them to ask questions, but they'd be an excellent resource. But aeronautical decision-making and human factors are key factors in NTSB, mishap investigations, and FAA actions as well. So I do think that we all know the I'm safe checklist. It's in the AIM in section 8.1.1. And the mnemonic stands for illness, medications, stress, alcohol, fatigue, and it says emotions. But a lot of the pilot operating handbooks have now converted over to eating and hydration, which I think is perhaps more appropriate. The only FAA regulation that talks about aeronautical decision-making in an aeromedical context is 6153, where it says you can't act as a pilot or command or required crew member if you have a medical condition that would impair your ability to fly, or you're taking a medication, receiving other treatment. So what's the challenge here? I would suspect that everyone on this call uses a checklist. It's certainly required, and we do it pre-flight, and we do it during our operations. And there's universal acceptance that a checklist should be used. Generally, it's in a standardized format, and the FAA requires that we do that. But the most likely failure point in aviation is not the aircraft, but it's the operator. And the operator can fail in sudden and subtle ways too. Many times in a powered aircraft, you get a red light or a green light, depending on whether a system is operating. But we don't have anything like that for ourselves, with a few exceptions that I'll talk about later. But we can fail in a subtle way too, so that we're not aware of what's going on. And particularly if we haven't prepared well, we may be more at risk for failing in a subtle way. So the FAA has a pilot personal minimums checklist, a trifold there, and this is the inside of the trifold. And when they talk about the pilot, if you look in that red box that I have there, you'll see sleep, food, water, alcohol, drugs, medications, stressful events, and illnesses, which is essentially the I'm safe checklist there. But they also talk about external pressures and how to prepare. And I must say that doing an honest assessment of your own personal fitness is extremely difficult to do. A denial is a powerful mechanism. So many times I will ask my students to check me out and see if I'm really good as we go through that I'm safe checklist. And likewise, I'll do that for them. So let's go through each of these one by one right now. So illness. Many people think, oh, just I have a cold and I shouldn't fly. But there are a number of illnesses that can adversely impact our ability to operate at our optimum here. Certainly with, I'm starting from the top and going down to the bottom. Headaches, if you have a headache, you're having vision problems, allergies and colds that are pretty common. Dental work can cause some significant pain. But we have a lot of our pilots who may have coronary artery disease or heart rhythm problems that may compromise particularly their cardiopulmonary system and their ability to oxygenate well, which we'll talk about in great detail a little bit later. Likewise, the lungs contribute to that. And we'll talk about smokers, but people with chronic obstructive pulmonary disease have reduced lung tissue. Looking at the GI and GU system, ulcers, irritable bowel syndrome, kidney stones, all of these things can cause GI distress, which gets exacerbated with the reduction in barometric pressure at altitude. Neurologic, there could be some residual from head trauma or loss of consciousness. Our science tells us now that even with head trauma, where we used to call it, oh, just a little concussion, you got dinged, but there's significant residual decreased cognitive function for weeks to months afterwards, even without loss of consciousness. In the musculoskeletal system, think about flying a glider for a long period of time with back or disc disease or joint pain, and how that might be distracting, being uncomfortable in the cockpit. And then there are a number of systemic conditions too that adversely affect our ability to fly. Sleep apnea is far and away the most common undiagnosed condition that results in cognitive impairment. I do a lot of fitness for duty assessments on pilots who are having problems in training or not following SOPs for their employer. And the most common thing we find is undiagnosed sleep apnea. And the FAA and NTSB have both made significant pleas to address sleep apnea. I will tell you that that is a nasty disease associated with diabetes, obesity, depression, increased risk of stroke, heart attack, and motor vehicle accidents if untreated. So if there's any doubt about that, I would recommend you get an evaluation. The most common statement I get from pilots who didn't know they had sleep apnea and got treated, usually with a device called continuous positive airway pressure, or CPAP, is I never knew I felt so bad before until I feel so good now. And then, of course, conditions like diabetes, cancer, particularly some of the hematologic or blood cancers, can lead to anemia. And then long COVID, or the medical term is post-acute sequelae of COVID, can cause problems both with cardiac and pulmonary, but also we found neurologic and hematologic now, blood as well.
Hey, Clay, one quick question.
Yeah.
Could you explain GI distress?
Gastrointestinal distress. So let's say you had a good Mexican meal last night, and you're coming back and to fly the next day, and that meal is coming back at you, or you have ulcers, or you have an underlying condition such as irritable bowel syndrome or Crohn's disease, different types of colitis, that particular food allergies can cause a feeling of acute diarrhea or bloating that would be significantly distracting. So if you look at the FAR Part 67, which are the medical standards, there are only 15 disqualifying conditions, and they're listed here. But most of us are not flying with those conditions, with the possible exception of some of the cardiac issues. But the the NTSB for 10 years had on their 10 most wanted list a desire to end substance impairment in transportation. And they were talking about alcohol and drugs, but they're also talking about medications. So we will talk about all of those here in a second. So with medications, there are many medications that are okay to take and fly, but we always have to consider what the underlying condition is. When a pilot calls me up and asks if he or she can fly with this medicine, the answer is not yes or no. The answer is, what are you taking it for? And why are you taking it? And it's really the underlying condition that is the most likely thing to be affected. However, the medication itself can be problematic. I would recommend that anyone ground test medication before they use it in flight to make sure they don't have any adverse effects or allergic reactions. You can check with your AME, or I'll give a free database from our company where we have over 800 medications listed in the FAA policy. There's some that are always disqualifying, and those are primarily the ones that cause cognitive impairment or sedation. With respect to sleep medicines, there are a limited number of sleep medicines that are allowed, but there are significant waiting periods after taking a single dose of those before you can fly. The FAA has a website. If you go to Guide to Aviation Medical Examiners, sleep medicines, you can see the waiting periods for all of those. And of course, we always have the 6153 responsibility to assess ourselves that we don't have a medical condition or taking medication that would impair our ability to operate safely. Now, we're from the great state of Colorado, where marijuana has been legal both in a recreational and a medical sense for over 12 years. But we all fly under federal aviation regulations, and marijuana, tetrahydrocannabinol, is a Schedule I drug and is prohibited federally. So we are not allowed to use any THC containing products, And I would warn you that many products that say they are cannabis only, no THC, are not advertising truthfully. To be called cannabis, it has to have less than 0.3% THC in it, but there's no quality assurance on that. And a number of professional pilots that I work with who may have tested positive for THC, usually it was innocent or unknowing ingestion of that. So be very, very careful about using any cannabis products as well as marijuana because of the THC content in it. The NTSB did 2 safety studies looking at the use of impairing medications in fatal general aviation accidents. The first one was a look from 1990 to 2012, and then they did a follow-up study that went later. But these are the number of, or the percentage of pilots with these substances in their system at the time of their fatal accident. And this does not count alcohol because you can't do a postmortem assessment of alcohol because of putrefaction of the body. But you see that as of 2017, over 25% of the fatal GA accidents had potentially impairing drugs. A smaller percentage had potentially impairing condition, and then controlled substances. Controlled substances are those scheduled substances like some of the sleeping medicines, the opioids and opiates that people may use, ketamine, things like that. And then illicit drugs would be also included in possibly controlled substances or things that might not be actually controlled and scheduled, but being used illegally. Such as MDMA or ecstasy. And the FAA took on a big campaign back in 2012 to highlight this, but despite their highlighting it, the trends continued in a bad direction. And 2023 was the first year where THC was a higher percentage than another drug, diphenhydramine or Benadryl. So this is looking at the pilots with positive toxicology and looking at age cohorts for them. And what you see is as we get older, we use more medications, no big surprise. But we also see a steady rise in the use of impairing drugs and drugs for impairing conditions and even controlled substances. The only thing that drops off with age is the use of illicit substances. And again, this study was done before any state had legalized cannabis production. So being older puts you at higher risk, or at least in those people who had fatal GA accidents. And this was the breakdown of the top drugs that were found. And I put arrows there by the ones that would cause cognitive impairment there. So you can see there's a substantial amount. The sedating antihistamines, 11.9%, and that was diphenhydramine and Benadryl. There are 2 other smaller ones that made up the 0.9%, chlorpheniramine and brompheniramine. But I'll just say right now, the current FAA policy is that if you use Benadryl, diphenhydramine, which is in NyQuil or anything that says nighttime or sleepy, it has that in it. The FAA policy is there's a 60-hour wait, 60 hours, so 2.5 days after a single dose before you can fly on that. Studies have shown that 16 hours after a single dose, cognitive performance is essentially equivalent to a blood alcohol concentration of 0.05% or close to driving while intoxicated.
Quay, I got one question for you.
Sure.
Actually, 3. I'm going to combine it into one. I think simple one here for you. Can you comment on caffeine, cannabis topical cream, and nicotine?
Okay. Caffeine is a performance enhancer. It's a diuretic. But if people are tolerant of caffeine, so their intake is in the range of 300 milligrams of caffeine a day or higher, They almost need caffeine to stay awake, and the withdrawal can cause some irritation. But it is a performance enhancer for those who are non-tolerant or caffeine naive. With the creams, generally you use the term cannabis cream. Usually it's marketed as CBD cream. Take your chances on that. People have tested positive, at least, and claim that they only use creams. Again, there's no quality control. It's not checked by the FDA. It's considered a supplement. So we really don't know what the content is. It's unlikely that people would test positive, but there's no guarantee. And the last one was nicotine. Nicotine, like caffeine, is a stimulant. It's a known stimulant. And also like caffeine, you can become dependent upon that and have a withdrawal syndrome. So people who are smokers, and later on I'll talk about why you shouldn't smoke, but if you are smokers and you're not smoking while you're flying or you're using oxygen, it would be a really bad idea to smoke. Maybe a nicotine patch or nicotine gum would be appropriate if you need to keep those levels up. I'm sorry, I tried to get these to come in a different color, but these are some websites that the FAA has. If you look at their do not fly, do not issue section, that talks about different drugs. Also, the FAA does not approve investigational drugs nor new FDA approved drugs if they've been out for less than 12 months. And of course, there's no approval of any drugs that are known to cause cognitive impairment. These are the links there, and we can get you the hyperlinks. But those are 3 aviation safety brochures that the FAA puts out specifically dealing with medication. Also, I'm not trying to be commercial and there's no money made on this, but this is our website. If you look up at the top there that's circled, you'll see a medication database and a medical conditions search. I've written articles about 50 different medical conditions and the aerospace medicine implications of those. And also in the database, you can go to the database and look at over 800 medications and the FAA policy on use of those medications. But again, remember, it's always the underlying condition that makes the difference. So we've done illness and medication, the IM of the I'm Safe stress list. So now we move on to stress. And all of us are going to have stress at some point in our lives. And it can come from multiple different reasons, but it's impossible to avoid stressors in our life. And the FAA has really dealt with this. These are organizations or committees that I've been involved in. We had the FAA ARC for following German wings and MH370 in 2015. Currently, there's an FAA mental health and aviation medical clearance aviation rulemaking committee that's going on. The NTSB had a 7-hour summit on navigating mental health. And then the European Aviation Safety Organization has a MeSafe program, which is extensive research on mental health. The International Civil Aviation Organization has a mental health working group. We met yesterday and we meet twice a month on that. And then the Aerospace Medical Association also has a mental health working group. And then there's the International Peer Aviation Assistance Coalition, which is a global coalition of all aviation professionals, not just pilots, but it includes maintainers, instructors, flight attendants, et cetera. So there's a huge emphasis on this right now. And if you look at the FAA's efforts, Dr. Northrop, who's the current federal air surgeon, puts out the Pilot Minute, about a 1.5-minute video. And 6 of hers in the last 3 years have been on mental health and stress. And there are a couple more that are coming out in the next few months. And she's on all of these committees with me as well. So depression. Unfortunately, depression is a very common phenomenon. The statistics in the US are that 20% of people each year in the United States will meet the clinical criteria for depression, 20%. Slightly higher in women than it is in men, but not much difference. And lifetime, about half of us will meet those criteria. Now, there are varying degrees of it, and from severe depression where people are suicidal or homicidal, like Andreas Lubitz in the German Wings, or there may be mild emotional disturbances that are persistent. The depression can come from intrinsic factors, such as a genetic component or a chemical imbalance. And in fact, all depression is really a chemical imbalance in the brain, either transiently or on a more permanent basis. But we know that there are extrinsic provocateurs for this as well. Pregnancy and postpartum depression, medications certainly can cause depression. In fact, some come with black box warnings for increased suicidality with that. And there are a number of medical conditions, particularly chronic medical conditions associated with pain that can cause depression. But the impairing part of that is we know that there's cognitive impairment with depression. And when people are treated for their depression, their cognitive performance improves in very quantitative studies and testing that we do. But depression is also associated with sleep loss and fatigue, difficulty getting to sleep, early morning awakening, and a chronic feeling of fatigue. And as pilots, we like to think we're superhuman, but in reality, we have the same prevalence of diseases as the general population does, and we're equally likely to suffer from these conditions. So alcohol and intoxicants, going back to the NTSB's top 10, impairment from medications or from substances. Alcohol is the drug of choice for pilots. I run the what's called the HIMSS program, the National Program for Returning Substance Dependent Pilots Back to Fly. We have over 11,000 pilots that have been through a treatment program, Return to Fly. 91% of them, alcohol was their primary drug of choice. And we use alcohol because it's encouraged basically as a stress reliever, inducing of social ease in just about every society. But what we find is with the FARs, with 8-hour bottle to throttle rule and a 0.04 BAC level, is that a lot of our pilots, particularly the professional pilots, will follow those rules. But in following those rules, they'll think that it's safe to consume 5, 10, 15 drinks 8 hours beforehand and then go back and fly. But their blood alcohol levels really haven't dropped enough that they would meet those criteria, even though they're following the time limits. Their blood alcohol or breath alcohol concentrations are above that. The FAA has a safety brochure specifically on this. And in the US population, 7 to 9% of the US population meet the criteria for a substance use disorder. And if you throw drugs on top of that, it's about the same percentage for drugs or non-alcohol substances, but there's an overlap between the two. So it's not the sum of the two. It's really probably 13 to 14%. And in the US, this was from last year, 15% of the US adult population uses THC on at least a monthly basis. In the younger population, it's a higher group. So again, that's federally prohibited for pilots operating under the federal aviation regulations. So what are some of the effects, even if you don't have alcohol on board? Well, the hangover is dehydration, excuse me. And there actually is brain cell injury, although that can be recovered. Certainly there's cognitive impairment in people who drink more heavily on a regular basis, have reduced cognitive scores. And when we take people who do have a problem and allow their brain to be free of alcohol or other substances for a month or two, we see their cognitive scores come up. We'll talk about the importance of REM sleep in a little bit, but alcohol absolutely destroys REM sleep. And REM sleep is important for learning and cognitive awareness as well as emotional clearance. There's a host of diseases associated with consumption of alcohol. And I mentioned the HIMSS program earlier. So people who do have a substance abuse problem, regardless of whether they're a professional pilot or hold any pilot certificate, can participate in that and be cleared. I realize that pure sailplane pilots aren't required to hold a medical certificate, but the effects of alcohol are the same even if you don't have a medical certificate. So let's move on to the F of I'm safe, and that's fatigue. And this is the ICAO definition that talks about a reduced mental or physical performance capability. But it only really talks about extended wakefulness, circadian, or workload. But there's some other issues that we'll talk about here in a second. Many of us on this call have read Lindbergh's biography, or when he talks about it. His flight was 33 and a half hours, but those of you who read the book realize that he was up between 64 and 68 hours for that flight. But I thought this quote from his book talked very well, as he was facing both acute fatigue and chronic fatigue, but also circadian desynchrony too. So he was hurting for sleep. It's amazing to me that someone could fly solo, being up that long in an aircraft that didn't have a window to look out of at all at night with minimal navigation equipment. So as I mentioned, there are different types of fatigue. There are acute, chronic, and circadian, which are mentioned in the ICAO document or definition. But there are also a lot of medical factors. I previously talked about sleep apnea, and there are certainly cardiopulmonary factors and mental factors that can contribute to that as well. And fatigue is almost always present. And so what you think about are usually the top 4 or 5, time that you've been doing it, but a much more salient issue is time since being awake. And Brandon, you asked the question about caffeine earlier. The longer you're awake, your body makes a substance called adenosine. Adenosine is the driver for sleep in the brain. And caffeine actually blocks the adenosine receptors in the brain. But the adenosine continues to accumulate. So using caffeine makes you feel more alert, but doesn't reduce the sleep drive when that caffeine wears off. The half-life of caffeine is about 4 hours. If there is a problem, particularly those people who are caffeine dependent, they may need a continuous dosing of caffeine during critical operations. Your pre-flight sleep and your phase of your circadian phase, and I'll show you a slide here and a slide or two about that, where it's potentially problematic for sailplane pilots, a workload. But many of us don't think about the contributions of environmental conditions, the cockpit comfort, the temperature, particularly being hot or continually shivering, lighting, and the sun and staring into that is problematic. We've already talked about medication. We've talked about the worries and also some of the health factors that can contribute to fatigue too. So just don't think about it as sleep, but many other factors. In a study, again, this was an NTSB top 10 item for about 6 years, to reduce fatigue-related accidents. And in a study of aviation-specific factors that fatigue exacerbated were these: fixation on part of a problem and losing the big picture, losing the situational awareness, impaired alertness, microsleeps. Those are those quick sleeps that your brain grabs when the adenosine levels are high. We've all been driving down the highway at night and gone past an accident and never knew that we did it, where you can be asleep with your eyes open, where your brain is actually in a sleep state, but your eyes are open because of the sleep drive being so great. And then you look through the others here. These are all things that directly adversely impact aviation safety. And I teach a course in fatigue risk management, and I have a an airline accident associated, a single one associated with each one of these situations as a result of fatigue. So there's the bottom line. Fatigue makes you stupid. So let's look at some sleep strategies to avoid fatigue. The bedroom, you want it cool, quiet, and dark. Cool. When your melatonin kicks in, your natural melatonin, not the one I have on the bottom there. What it does is it slows down your heart rate, but it drops your body temperature by 2 to 3 degrees. And to get sleep, you need to drop your body temperature so you can assist that with cooling down the room. Quiet, you get relaxation of the muscles in the ear that serve as shock absorbers. So when you're falling asleep, it actually, sounds are actually louder because you don't have that dampening effect. Dark, any light will suppress melatonin. And recent studies have shown that darkness isn't, the more dark you are environmentally in when you're sleeping, it's an independent factor of light and daytime and any other thing. In a study of 87,000 British folks, it was protective against depression, mental illness, and schizophrenia. So not having lights on in the room where you sleep is good. If you have a regular pre-sleep routine, that will help you get to sleep. You're essentially doing a Pavlovian type conditioning. You're going through the same thing each time before you go to sleep. That would be great. Melatonin, I don't recommend melatonin except for circadian desynchrony, jet lag, because your body makes it and it's time based on the light. So if you have a normal work schedule and you're up during the daytime, taking exogenous melatonin, number one, you don't know how much you're getting because, again, it's not FDA regulated. But two, it suppresses your body's melatonin. So when you're trying to get to sleep, it impacts that. And what are some behaviors you can do to help you get to sleep? Well, as I said, avoid alcohol. Now, alcohol is a great sedative. It will make you sleepy initially, but it destroys the REM sleep, as I said earlier. And REM sleep is where you get the cognitive and emotional repair. Avoiding caffeine with 4-hour half-life. So ideally no caffeine within 8 hours before you go to bed. Blue light is known to suppress melatonin. There's some recent controversial studies that may say it doesn't affect sleep, even if it does affect melatonin. A light protein snack will help stabilize your blood sugar so you don't get these wild swings with insulin production and blood sugar levels, which can cause irritation, wakefulness, etc. And then a short hot or warm shower. The reason we talk about that is your blood vessels dilate in your skin. It helps you lower your core body temperature. You don't want to take a hot one to raise your body temperature, but a short one will allow your blood vessels to dilate and your body to cool. Likewise, I left it off here, but trying to avoid exercise within 2 to 3 hours of attempting to sleep, because exercise, particularly more strenuous exercise, will raise the core body temperature, and that will adversely affect your ability to sleep.
Corey, I have one question.
Yeah, Brandon.
What are the long-term effects of, I guess, long-term use of melatonin?
So there's conflicting studies about this. It's not something that you get dependent upon and have a withdrawal syndrome like you would with other conditions. And eventually, with the time away from it, your body will start making melatonin in its normal cycle. But if you're using it on a regular basis, you won't get that sleep drive, except for the adenosine that comes into the brain that accumulates with time awake. So I can't say it's dangerous. That would be too extreme a position, but I can say that it will interfere with sleep regular sleep at the normal times if you're using it on a regular basis. The other thing that suppresses the body's production of melatonin is bright light. So I travel around the world all the time and I have to play these games with circadian desynchrony. But I use light and I don't use melatonin in those situations. Oops. So the last part of the I'm safe checklist is the E, and I've used eating and hydration rather than emotion. This is particularly challenging when we're doing our long cross-country flights where we may be up for 4 or 5 hours or longer if you're some of the guys in our club will go out for 7 or 8 hours at a time, and you folks in Boulder who fly forever too. But you want to be strategic in your eating, and the goal is to maintain a stable blood sugar. If you're having swings in your blood sugar, your insulin levels are going up and down, and that's associated with increases and decreases in catecholamines. I'll use the term adrenaline, epinephrine, norepinephrine. Those are things that can impact adversely your cognitive function if you get these big swings. So the way to do that is to ingest proteins and complex carbohydrates, not simple carbohydrates or sugars or things like that. Clearly, just for general health, you want adequate but not excessive calories, and you can go with more frequent eating. But when I think about the sailplane, what do I use? Well, I think about, I don't want anything that's going to melt. I don't want anything that's going to crumble, so mice come into the sailplane later. And I don't want any simple sugars that are going to spike my blood sugar and then make it fall precipitously. So I find that string cheese meets my requirement with that. Some sports bars, not the chocolatey ones, and the dried fruits also work very well on that. And of course, we need to make sure that's ease of access because of the very, very cramped size of the cockpit to make sure that we can get to them while maintaining control of the aircraft and not trying to unbuckle your parachute or anything like that. For hydration, excuse me, generally we run a little dry. If we were an automobile, we might be a half a quart low is our normal status. For men, we need at least a gallon per day, and this is our resting requirements. If you've been pushing your sailplane down to the end of the line, you are flying and the sun is out and you can't tuck underneath the cloud to cool off, your requirements are going to go up higher. So generally in the US population, we do run a negative gap, and I would encourage hydration. I personally fly with 6 liters of water in Camelbacks behind my seat when I'm flying, just to make sure I stay hydrated, because all of the medical factors that I talk about are complicated by and the adverse effects increase in a dehydrated environment. So what do I look at? I think about the urine being light yellow to clear, and then we're probably in good shape. Alcohol and coffee, you shouldn't be doing alcohol before you fly anyway, but they're diuretics. So that means that's a net fluid loss. It makes you urinate more than what you take in. Sports drinks are good because they have electrolytes in it, but again, be judicious about how much sugar you put in there. There are some low sugar sports drinks that may be a little bit better, but as long as it's not super saturated sugar in the sports drink is not a big issue. With the Camelbacks, there are pressure changes, but as long as you take off with the air bled out of the Camelback, that shouldn't be a problem with the hydration. And I would strongly suggest that you have a relief system in your aircraft. I think my next slide has an article in Soaring Magazine by Garrett Willett, which was really good about that. But I am aware of some pilots who don't have a relief system in their aircraft. And as a result, they tend to dehydrate themselves, and that is not a good solution for safe flying. Yeah, there's the article by Garrett Will in Soaring Magazine, December of 2019, page 40. I would strongly encourage anyone who doesn't have a working elimination system that they read that article and do that. As far as gastrointestinal, solid foods, avoiding fiber, so you don't have an urge to have a bowel movement, and the spicy foods. But if you get up to 18,000 feet, because of the reduction in atmospheric pressure there, your GI volume is actually double from what it is on the ground. So you get a strong bloating sensation too. So you want to get rid of that. And then going back to the urinary elimination, there are a bunch of different solutions to that, all which work, and just find your own preference, but use it on a regular basis if you are going to be flying cross country. Let's talk about thermal comfort, okay? So we all know the dry adiabatic lapse rate is 5.4 degrees per 1,000 feet when you're going up. So I'm going to do a little public math here. Kelly Air Park is at 7,000 feet, so 80 degrees Fahrenheit on the ground, and we go up to 17,000 feet. Okay, what's the temperature up there? It's below freezing. It's about 26 degrees. Okay, so we need to be prepared even on the warm days to protect ourselves from the thermal problems we have. So layering the clothing, clearly inside a cockpit, it's not easy to, it's impossible to put on and take off clothing, particularly if you're wearing a parachute, other than something on your hat or gloves. So zippers with Velcro, with pants that will open up or shirts that will open up, having the cargo pockets so you can store some food in there, gloves or hats that you can access easily. And then, of course, you want some UV protection while you're up there, both for your skin and your eyes. And we'll talk about vision here in a second. And then we can use clouds and sunshine as our air conditioning and heaters. And many times when it's been too hot, we'll fly under a cloud and cool off a little bit, or getting too cold, try to get out in the sunshine. Of course, the lift isn't always exactly where you want the air conditioning and heating, but it is a strategy to do that, which works fairly quickly. I just threw this slide in because as I look around our soaring club, we have a nice group of youth, but they tend not to fly cross country. And as we get more gray hairs, we tend to fly a little more cross country. But this was a study out of the Naval Aerospace Medical Institute about cognitive function with age. And on the horizontal axis, you see various age cohorts. And these are on 24 neurocognitive abilities that are specifically related to aviation. And what you see is a linear decline as we get older in our cognitive abilities. But what you also see is a wider spread as far as the standard deviation, so that those people who are even in their 70s and 80s, essentially, if they're at the top of their game, they're functioning like a young person in their mid-20s. So the purpose of this talk today is really to talk about being at the top of your game so you can be at the top of those blue bars, despite the inevitable decline in our physiologic and our cognitive abilities as we get older, which become very, very important when we're flying cross country. So here's just one slide I made talk about how to optimize your cognitive function. My mom, she did go to college, but it wasn't medical. She had lots of good advice, and we went down there, get 7+ hours of sleep a night. Make sure you don't smoke. Reason smoking is cigarette smoke or other types of smoke now with vaping and cannabis have carbon monoxide in it. Vaping, not so much. But carbon monoxide binds to the hemoglobin molecule and prevents oxygen from binding. So heavy smokers can be essentially at a blood oxygen saturation similar to someone at around 10,000 feet. if you're starting from sea level, and then it just gets worse as you get up there. Minimizing alcohol, the old recommendations were men up to age 65 could have 14 drinks a day, and women 7, and men over 65, 7 drinks a day. Now, the National Institute of Alcoholism and Alcohol Abuse and the National Institutes of Health are saying that any alcohol is adverse, and probably more than 2 drinks in a week has some negative effect on you, although it may be very incremental. Already talked about the healthy diet, but if you want to be cognitively aware, particularly as we get older, you need to do something to challenge yourself mentally. There are different ways you can do that. Also, what you're doing today, recurrent aircraft training, just stimulating your brain. The WINGS program is a great program with lots of courses on there, and also challenging people to meet either the private or commercial standards if they're doing the flight credits as part of the WINGS program. We've already talked about reduction of medication, strategic caffeine use. If you are a caffeine user, make sure you have some caffeine on board and available during the duration of your flight. The strategic light exposure, said that helps with sleep and melatonin levels. So getting a good dose of light, particularly in the morning, and reducing the light exposure at night. And then as a result of this aviation rulemaking committee and studies that we've researched for that, we've found that for mental health, meditation, spirituality, prayer, and or whatever you do in that area to just become introspective as far as what's happening to yourself and isolating out all the other external stressors that are going on has a positive effect on both mood and even cognition. So when I'm flying or when I'm at work, and we represent about 100,000 professional pilots and air traffic controllers, and they call our office and say, can I fly with this condition? And again, or they say, can I fly with this medication? As I said earlier, I don't answer with, yes, you can. I say, what are you taking it for? What's the condition? But the bottom line is, would you put your family in a single pilot aircraft with the medication or the condition or the situation that you just described to me and trust that you'll be fine? But unfortunately, most of us don't do that in an objective fashion. And my plea to you is to assess yourself physically, emotionally, and cognitively to make sure you're ready to take that flight that you've planned and any emergencies that might arise that you can handle appropriately. So that's a quick summary of that. I do plead with you, just like you use your aircraft checklist, use a personal checklist, make sure you go through the I'm safe. Brandon, I think I'm going to go into some more specifics here, but are there any questions that have popped up before I move on?
No, quite. There's not. I think the rest of them I'm either answering them because they're kind of one-off questions, or we'll wait until the end. But
Okay. Then I'll move on. Oh, these are some of the resources. And this will be available, but the FAA has quite a bit of resources. I started out by saying they're not readily available, but they are out there if you're willing to search the FAA website and download this information. Both the safety brochures, the pilot information brochures, the Federal Air Surgeons Medical Bulletin. And if you want to get geeky and go into the research, you can go to the CAMI library, and they have all the research papers. And then the AIM talks about these specific particular issues that we may face while we're flying. So I would encourage you to read Chapter 8 of the AIM. Okay, well, let's talk about vision. Okay, and we'll talk about clearing and scanning techniques, your visual acuity, and other things that will make you a better eagle-eyed pilot out there. So I don't know how many people have been taught about how to scan appropriately to look for other aircraft, but the eye is a unique organ, and in the central 10 to 15 degrees of vision is where you have your best visual acuity. That's where you see 20/20. Peripherally, as you go further out, even with correction, you're really only seeing 20/40 close to the central portion of the eye, called the macula. And as you get further out, you're getting to 2200. But what the peripheral vision is particularly good at is detecting motion. It can't have the acuity to see exactly what's going on, but it's motion. So the scanning technique takes advantage of this part of your physiology. And rather than sweeping your eyes across the horizon, if you're doing that, you're losing the ability to focus with your central vision. And because your eyes are moving, you lose the ability to detect motion. So the best strategy is to pick about a 15-degree segment of sky and look at that for 3 to 5 seconds, and then move to the next sector and hold that. And then assuming the first one was straight ahead, you might look left 15 degrees for 3 to 5 seconds, and then right, or return. Certainly scanning on the horizon is the most important because that's where you're most likely to be hit from. But my strong recommendation is do not sweep your eyes across the horizon. Pick a segment, focus on that, 3 to 5 seconds, and move on from there. So your visual acuity is best in bright light, and your contrast sensitivity, which allows you to pick up gradations in color. But think about white sailplanes under white clouds. It's reduced under the clouds there. So that's potentially problematic. Best in bright light. I find myself struggling a little bit between wearing sunglasses when I'm flying, which perhaps darken things too much, and I lose a little bit of that acuity, and those that keep me comfortable. Clearly, if you stare into the sun, you're going to get a temporary flash blindness from that. And that can reduce your central visual acuity for several minutes, possibly on that. It'll come back gradually. Hypoxia is one of the biggest causes of reduced both color vision and acuity. If you've done the military hypoxic chamber, hyperbaric chamber, or the FA now has Robar device, reduced oxygen breathing device, where you can do that training. I highly recommend that. But you notice the first thing you lose is your color vision, and then your acuity starts to go down too. And that's directly related to blood oxygen levels. And as we get older too, we're more likely to have cataracts. And we may not notice that we have cataracts, but it distorts and obscures portions of our vision. We notice it when it's in our central vision and we can't see very well, but it's just off our central visual axis. We may not be aware of objects that we're should see in our visual field. The way we would detect that is if at night you're driving, you're starting to see some glare and flare and halos. And presbyopia, that's the arms aren't long enough to read things and the instruments are there. And particularly if you use the smaller diameter instruments, a little more difficult to read. So there may be some advantages as well as disadvantages in using the progressive lenses, or at least having bifocals or even trifocals. For eye fatigue or comfort, sunglasses definitely reduce the fatigue, but you want to use a neutral color so that colors are preserved, and you don't want polarized lenses. The reason you don't want polarized lenses is some of the instruments are polarized, but also if you're looking for a wing flash or a flash of sun off of a glider, polarized lenses will suppress that, and you won't be able to see that as well. It would be best to have gradations like the illustration I put up there, so that you can read your instruments better in the lower visual fields, but have the protection in the upper visual fields. You do want to block light from peripheral, so something not necessarily wholly wrap around, but at least something that protects the eyes from the side. I don't like the idea, though, of the leather collars that go on there, because that totally blocks the vision there. Also, if you have something that shields it from the brow, it prevents perspiration from dripping down. Most lenses now do have UV blocking, and you can order lenses with different light reduction factors. You can get lenses anywhere from 40% reduction down to about a 5% reduction in that. I like to use I'm blanking on the name, a little cord that goes around it so I can drop them off but not lose them. Go from there, and I've already and put them back on when I need it, particularly if I'm flying back west. I've been out east, I'm flying west near sunset. I want to make sure that those glasses I stored are easily available to me. And I've already talked about the advantage of bifocals and progressives, if you can use them when you're flying to help you better interpret your instruments. Okay, so the environmental hazards, the glare, we've talked about that, not using the Polaroid lenses so you can see the aircraft when you do it, but you want to make sure your canopy is clean so that you can increase your chances of seeing other aircraft that it's out there. And when possible, I realize this is the impossible dream, but having the sun behind you is always advantageous when you're doing that. So if you do have different options about how to plan your route on your cross-country flight, thinking about when the sun might be in a low angle and interfering with your vision, if you can avoid that direction of flight, flying west late in the day, that would be ideal. When you're in a low contrast situation, such as cloud, haze, rain, smoke, fog, anything like that, or even late time, get those glasses off, because the glasses are reducing your contrast sensitivity and your ability to detect other aircraft. Dryness is a problem for some people, so make sure you're blinking frequently. And I do know some people who regularly carry some saline eye drops to help. The FAA has a nice brochure about selecting sunglasses for pilots, and most of the material I presented comes from that brochure. Any eye questions, Brandon?
Yeah, Corey, I got two of them here. What's the definition of a neutral color sunglass?
So that picture I had right there is a fairly neutral color. It's not like a dark green or the silver reflective type things. And a lot of people want to be cool and will wear the Oakleys that are bright silver or bright red or something like that. That you lose color discrimination when you're doing that. So the neutral ones, like I have portrayed there, are best for color preservation.
Okay. And last question on this is prescription sunglasses. Any comments on that?
Good idea.
That's what I was thinking too.
Yeah, I mean, as opposed to having prescription glasses and then putting sunglasses over top of it, I think the prescription sunglasses are a much more easy thing to handle in the cockpit.
Okay, thank you.
Let's talk about hypoxia a little bit. So we talk about a breath of fresh air. It's really a breath of oxygen that gets you there. So we're going to talk about a little bit about the history of hypoxia in aviation and go through some of these things. I realize the time is advancing on me, so I may go through them a little more quickly here. But the history of it, Father Acostia was the first person who made a ground-based observation about possible hypoxia there. He kind of got it right almost, but it was the first statement I could find in the history that really talked about sensation of hypoxia. Then we move on to the researchers of Glaswell and Glasher and Coxwell in England. They went up in a balloon and they made some great observations. So at about 15,000, I'm sorry, that's about 18,000 feet, their pulse went up as they went higher. They noticed they were breathing faster, and they noticed cyanosis, the loss of oxygen from the hemoglobin, and the hands and lips turning blue. And they vision went down at that point. They couldn't read their instruments. Progressed with nausea and vomiting, and then muscle weakness and loss of consciousness for 7 minutes. Coxwell saved the life. He was, because he had collapsed, he was able to pull the balloon cord with his teeth and collapse the balloon. And then Paul Barrett was really one of the fathers of aviation medicine. And he talked about experiments in atmospheric pressure, realizing it was the decrease in pressure, not the reduction in oxygen, it's the reduction in the oxygen temperature. He was the first person to do an altitude chamber. So here's his picture, and he actually published a study on this. And he said that 45 millimeters of oxygen tension, hemoglobin oxygen tension was the limits in life, and that'll be important in another couple of slides. He did describe altitude sickness and decompression sickness, and also oxygen toxicity. So these three folks wanted to break the record that we talked about earlier, where Coxwell pulled the balloon cord with his teeth. They trained in Paul Barrett's chamber, but their criticisms of him from their balloon experiments was it wasn't cold enough in the chamber, they weren't active enough, and the chamber went up too fast and too slow. But they decided to break the record, and they didn't take enough oxygen with them, and Descendier died. I'm sorry, 2 of them died, and Descendier lived, but they reached 8,500 meters. So just trying to do a little public math, that's probably around 28,000 feet. And here's the sarcophagus to them in Paris for their heroic but deadly flight. And then in the military, we know Hubertus Stronghold as the father of space medicine. He talked about the atmospheric equivalence. So he was looking at breathing 100% oxygen at different altitudes, and whether it was survivable. And what he found is that at 16 K above the altitude, the water pressure of blood is 87 millimeters of mercury. So even if you had 100% oxygen, there would be no oxygen in your blood. And at 20,000 K, which is about 63,000 feet, water boils. So I've been in the U2 altitude chamber and watched water boiling in a chamber that I was sitting in. Fortunately, my blood didn't boil because I was in a pressure suit. But most importantly, at 33,000 feet, 100% oxygen by mask only gives the sea level equivalent unless you start to get pressure. And those of us who have been in the Air Force know that the pressure breathing kicks in right around 30,000 feet. So how do we define hypoxia? You got the geek definition above, and you got the pilot definition down below there. Our tissues aren't getting enough oxygen for a variety of reasons. And there's 4 different types of hypoxia. The less common ones are the hypemic hypoxia, where the blood, actually the hemoglobin can't carry that. So again, you got carboxyhemoglobin, or as a result of carbon monoxide exposure, which are smokers, people who are anemic will have this, so they just won't have enough oxygen or red blood cells with hemoglobin to carry oxygen. And a lot of drugs will cause a reduced ability to carry oxygen. You have the histotoxic, where the actual cells themselves are poisoned and they can't use the oxygen that's available. And alcohol, narcotics, there are different poisons. Cyanide is the most classic one that acts fairly instantaneously. You also have stagnant hypoxia, which may be a little bit of an issue when you're flying, but usually not that much, because you're not pulling G's, and you're with the cockpits that we use, you're usually in a semi-reclined position. So you're still getting adequate blood flow to your brain and to your lungs and heart at that time. But it is a potential problem, and it's exacerbated by cold as well. But the most common type of hypoxia, and the one we're most familiar with, is called hypoxic hypoxia. And what that is the alveolar exchange, or the exchange between the air and the tissues of the lung is not getting enough oxygen, so that the blood molecules that are flowing through the lung are not getting oxygen attached to them, so they can't carry that oxygen out to the tissue. And that's a result of the reduced pressure that's available. We have gas mixture changes in what are called the ROBARB devices, reduced oxygen breathing devices. If you go to the FAA seminars where they have that, they're actually substituting nitrogen in for oxygen to simulate reduced oxygen. But basically, the lungs don't get the oxygen to the blood. So what are the FARs regarding this? Well, 91-211 talks about supplemental oxygen. I think all of us are familiar with those rules. That no, it's required if you're 30 minutes above 12.5 to 14, above 14, and it has to be available for the used by the crew, and above 15, it has to be available for passengers. But many of us will use oxygen at lower altitudes, particularly those people who come from sea level. And 91B talks about pressurized aircraft, which, unless you're in the Perland project, is usually not an issue with gliders. But here's the oxygen saturations. I want you to pay attention to this, particularly the right-hand column. This is the percent oxygen saturation. And if you were breathing ambient air between sea level and 10,000 feet, you really wouldn't be aware of it, and your body doesn't have to compensate too much. But you can see that your hemoglobin oxygen saturation drops down to 90. And I would say that's probably the minimum that you want to tolerate. I personally have a pulse oximeter, and we'll talk about those in a second, to make sure that I'm getting the appropriate amount of oxygen. If you are breathing 100% oxygen at 34,000 feet, you would have the equivalent of sea level, and 39,000 feet would be the equivalent oxygen saturation as 39,000. And then going across the chart, between 10 and 15, so again, 12.5 is where we're required to use oxygen. If we're more than 30 minutes, we're in a compensatory state where you start to hyperventilate, and you can get some other changes. If you're living at that altitude, we'll talk about kidney changes later. Above 15,000 feet, you're getting disturbances, and you see your oxygen saturation dropping below 80. And you get to 20 or 25,000 feet, your oxygen saturation drops significantly to an area where you're potentially cognitively impaired. So if you go back to my slide on Paul Bear, which I'm not going to go to, he talks about the alveolar concentration, the limits of life at 45. So I've outlined that. Now, clearly people who ascend to Everest, and there have been a few people who have ascended without oxygen, they go through an adaptation process. But when we're flying gliders, we're not going through an adaptation process. Those of us who live in Colorado are partially adapted, and we do tolerate lower oxygen saturations because of changes in our blood pH. So we can release oxygen easier. But people coming from sea level, this is where their oxygen saturation is. I don't want to spend too much time on this. I just say that depending on how you adapt, your kidneys change the pH in your blood and can make oxygen more available to you. So you get more alkalytic as you accommodate to higher altitude. Here's another representation. What's important about this is you look at the oxygen tension that people have, and you see that blood has a remarkable capacity to carry oxygen and maintain the oxygen saturation. So on the vertical scale, you see oxygen saturation in the blood, and on the horizontal scale, you see the oxygen that's available that you're breathing in. So at sea level, you're breathing in about 100 millimeters of mercury pressure of oxygen, with sea level pressure being 760 and oxygen making up about 21%, you're getting about 100 millimeters of mercury pressure. And you see that sustained going down for quite a bit. The oxygen saturation stays high, and that's why you get that flat part of the top curve. But once you get below 90%, your oxygen saturation starts dropping off precipitously. And along with that goes vision, goes cognitive impairment, goes fatigue. So that's why keeping that oxygen saturation a level of 90 or above is particularly important, because even at 90, we're experiencing lower oxygen concentrations. For me, I get to about 12,000 feet and my oxygen saturation will go down to 90 to 91. So what are the subjective effects of hypoxia? I'm not going to read through them all right here, but none of these are good for your cognition while you're flying and making good judgments while you're out there, okay? And if anyone's been in the chamber or used the reduced oxygen breathing devices, you'll have specific symptoms that are very much reproducible each time you're exposed to a hypoxic environment. I know that I get flushing of my face each time. The first thing I get is this feeling like someone's pouring warm water over my face. And that is my symptom. But if you do have a chance to participate in any of the FAA training or have access to any sort of hypoxic training, I would strongly recommend that you take advantage of that, because it is an important warning sign for you that you can remember. And the FAA does a fantastic job of training people in that. Here are some of the objective things that happen. You get an increased breathing rate, which were noted in those studies I showed before. You get cyanosis or blueness of the skin. So you can see it in your fingertips or your lips or your ears. Sometimes that's a little difficult unless you're carrying a mirror with you. Your heart rate goes up, coordination goes down. But what's most critical is the reduced effective performance time. And this is where the FAA calculates out emergency exits, I'm sorry, not emergency oxygen requirements to make sure that pilots who have a sudden decompression will have enough time. And we're talking about reduced useful consciousness. Your time of useful consciousness is about 15 minutes at 18,000 feet without oxygen. It varies depending on each person's physiology and their conditioning and those things that I talked about before to make yourself the best version of yourself. So many people get confused between hypoxia and hyperventilation, and they're two distinctly different things. But there's some commonalities between them that make it confusing. With hypoxia, the key thing is you have low oxygen versus hyperventilation where it's low carbon dioxide. Okay? Hypoxia, you're generally not aware. You get that euphoric feeling. Basically, it comes on you subtly. And it stimulates you to breathe a little bit. But the key physical warning sign is the cyanosis, blueness in the lips, the fingertips, the extremities that aren't getting quite as much blood. And it can lead, as I've already alluded to many times, impaired cognition and loss of consciousness, particularly if we're going up particularly high, and we'll show you a couple of accidents. The treatment for that is oxygen and descent. Well, let's talk about hyperventilation. You may be aware because you get your increased respiratory rate, but as you increase your respiratory rate, you're dropping your carbon dioxide, and it's actually carbon dioxide that drives you to breathe. So it may suppress that. And as opposed to the blueness you get in your fingertips with hypoxia, you'll get tingling in the lips and fingers. And that's a good way to distinguish between the two. Hyperventilation is generally associated with anxiety, so you are generally aware of that. And the treatment for that is to slow your breathing down, hold your breath, or if you have a mask that allows you to rebreathe, to use the rebreathing features of that as well. And of course, on the ground, people say, breathe in a paper bag. You know, if you have your food in a baggie or something like that, that's something you can do while you're flying in a sailplane. And these are all the factors that affect, or some of the factors that will affect hypoxia. I think I've alluded to most of those down below before, but your rate of ascent, you know, if you're fortunate enough to get a 20-knot thermal and you're going up quickly, you may want to hit your oxygen early because that's going to make you hypoxic. And of course, the longer you spend at altitude, the more you're at risk for hypoxia, because even with the oxygen systems we use, we're flying at a reduced oxygen tension compared to what we do on the ground. Here's a picture of the Perland project here, where here are some of the countermeasures. Generally, I don't know any of us who have aircraft pressurization except for Jim Payne there on the right. But we can have supplemental oxygen, and there are different types of supplemental oxygen, and we'll go through those. Let's talk about perhaps the most common one is the Mountain High EDS system. And it's a variable pulse demand system that conserves oxygen in your tank. And it has 8 flow settings on it. There was testing and approval by the FAA, but not specifically on the EDS there. But the approval is for use of nasal cannula up through 18,000 feet. And that will keep you at an oxygen saturation at 90%. And using the face mask, particularly with face masks with rebreather, is adequate up to 25,000 feet. Above that, you need to have a sealed mask, and then above 30,000 feet, you would need to be pressure breathing. And there is an FAA technical report on the Mountain High website that you can look at that talks about the testing that they did. So let's look at the 8 settings on the EDS that they have. The night or now, that's continuous. That's you get puffs of oxygen with inspiration at any altitude. The D5, you start getting oxygen at 15,000 feet. So I'm sorry, 5,000 feet. So in Colorado, if you put it on D5, you're getting oxygen all the time since we started at a higher altitude. My personal choice is to use the D10 setting and start giving me oxygen at 10,000 feet. The others are face mask settings, but it provides oxygen at all altitudes plus increases the relative amount you get. The reserve manual mode gives maximum flow of oxygen at all altitudes. So if you are hypoxic, you'd want to go to the reserve manual mode. Hopefully you're cognitively aware enough to do that. But one thing that I do before I land, particularly if I've been fortunate enough to be up for a longer period of time, I'll set mine at D5. So I'm getting oxygen with every breath before I enter the approach, the pattern, and the landing as a critical phase, just to make sure I'm fully oxygenated. Also make sure I'm fully hydrated before I do that. I want to give myself every advantage to make the best landing at a critical phase of flight that I can. So there are different types of monitoring devices. I do have a pulse oximeter in my aircraft, and I monitor that. There are some problems with that. You can look at different pulse oximeters that come out there for varying prices. Price doesn't necessarily correlate with quality, but there are some good ones out there. And of course, sport watches also now can do that. I know a couple of us have the Garmin Forerunner 945 has that on it, and some of the more advanced versions. But some cautions with that. With hyperventilation, it gives you false high readings. So if you're hyperventilating, don't trust it. Also, if you're cold, you get reduced flow to the fingers, and it may not be valid. So try to run it with on a warm surface, a body surface area that you have. Um, and also, what I noticed, so just going through the hyperventilation, you're going to lower your carbon dioxide. So normally it's 40. If it goes down to 35 or it goes down to 25, then the oxygen concentration in your blood will only be 77, but the reading could say that it's up to 93. So just be real careful with that. The World Health Organization has a pulse oximetry training manual too. So I put the URL there for that. And then this is a holdover from our military days, and I still do this. What's called a price check. Periodically when I'm flying, I wish I could say I did it every 15 minutes, but I'm probably in the neighborhood of once an hour doing it. I go through and check the pressure, make sure I have enough pressure. I don't have a leak in my cylinder. I check the military was the regulator. Here it's the EDS setting, that it's on the appropriate one. And make sure I'm not getting any hypoxic alarms or no flow type alarms on there, and know the different types of alarms, the single beep, the triple beep that you can get on the EDS system. If there is any problem, I'm checking the connections and the tubing. And before I take off, I'm trying to make sure that my tubing is not being bound or crimped by anything else in the cockpit. And then in an emergency, know to go to the reserve manual mode or just the daytime mode, which you should get it. And again, the cure is to descend immediately. And you can get some substantial clearing of your cognition as you descend in altitude. For the sake of time, I'm going to skip, I'm just going to briefly show these accidents. I'm not going into great detail. But here was one accident in Minden. Basically, it was pilot incapacitation and hypoxia and high altitude glider flight that broke up. Here was another accident. Truckee person spent a lot of time. Remember I said time and altitude was a problem. He spent a lot of time at a high altitude and hadn't been getting enough supplemental oxygen. He had an oxygen system, but he was a mouth breather and overran the runway for that. Here was another oxygen system where the person actually used the Air Force, the A-14 mask, diluter demand, which you need to usually wear with a hockey helmet. At least that's what we did when we were flying at the Air Force Academy in those, to keep the mask on your face under pressure. But in this case, the person went to a higher altitude than what that oxygen supplementation system was capable of. Went to almost 39,000 feet. Here's the long description of it. But basically, loss of consciousness there. And for the time that the pilot was incapacitated. And then unfortunately, most of us are familiar with this boulder accident with a combination of diabetes and hypoxia in there. So hypoglycemia, remember I talked about medical factors can exacerbate the effects of hypoxia there. So here we have a combination of a low blood sugar level and a diabetic pilot, perhaps not able to control his blood sugar adequately while in flight or to monitor it adequately in flight. And then getting hypoxia with a sustained period of time, and unfortunately a fatal mishap with that. So here's some FAA documents on hypoxia that we have, and these are more technical reports. Tom Nessus is the person who is the primary author on those, and there's also a great researcher on fatigue too. So you see that name there, anything with hypoxia and fatigue, it's done by a really well-informed person. Here's some other references that I have from Brent Blue and different people, the Ernestine and Gradwell limitations That's a nice one on pulse oximetry, and that's where I found out that information. Hyperventilation will give you artificial high readings on the pulse oximetry. Soaring Magazine, Dan Johnson wrote a really good article about 10 years ago or 12 years ago now, I guess. And then, of course, the FAA safety brochure that's out there. And then the FAA has a series of publications and more safety brochures. So what are my recommendations? One, use oxygen. You know, don't try to be cheap. Don't try to conserve oxygen. Use it because your life depends on it, literally. Make sure you fill your bottle before flight, or you have enough pressure in your bottle to last you for that entire flight, plus any emergencies. If you had to go to 100% oxygen, that you could do that. Make sure if you're using a device like an EDS, you have good batteries in there. The price check, pressure regulator, indicator, connections, and emergency due before flight. Pulse oximetry, it's a nice validation that you're getting enough oxygen, but remember, it's not accurate if you're hyperventilating. And if in doubt, you think you might be hypoxic, don't sit around and ask questions about whether you might just descend and be safe and live to fly another day. And don't be one of those NTSB statistics. Any questions on hypoxia, Brandon?
Yes, I have 3 questions here. Does alkaline water help with O2 absorption?
I can't answer that question. I'm familiar with alkaline water, but I don't know if it helps with O2 absorption. I know that the kidneys will change the pH of the blood, but to a more alkaline, which helps with the oxygen. But I don't know ingesting alkaline water translates to the effect of the endocrine changes in the kidney that drive that. I'm sorry, I don't know. I suspect not, but I don't know.
Okay, second question. In relation to high altitude in gliders, can we use the medication Diamox?
So Diamox is a diuretic that is used to prevent, I'm sorry, not prevent, to reduce the symptoms of altitude sickness. So generally that's not a solution because it's a diuretic. You're going to get dehydrated from that and probably not able to take in enough fluids. And if you're getting altitude sickness, you're taking Diamox to prevent it. You're getting altitude sickness because you're not getting enough oxygen. So the solution is get some oxygen and descend.
Okay. Last question. Do you know where you can find resources to do hypoxia training?
Yes. So I'm sorry, not the Air Force, the FAA has a traveling show that about once a week at different locations, they use this reduced oxygen breathing chamber. They put 5 people in there. They give you about a half hour of education beforehand, which is very, very well done. They put you in there, you're doing math problems and writing your name and answering questions, looking at a color wheel. So the whole process takes about an hour. They also have that facility at CAMI. They used to have a oxygen hypobaric chamber, but I think they recently got rid of that for these 2 Robar devices. So if you contact AAM 400, that's the education division of the Civil Aeromedical Institute, they will have a schedule about where that device is that you can do that training. I know they're booked a year and a half in advance already. But they can do it. I got a convention I was at. They were training close to 70 people a day. And it was walk up.
Okay.
Okay, I didn't change the date on that one because I gave this one a while back, but let's talk about mitigating fatigue here. I realize we're getting late and everyone's getting tired, so I'm not going to fatigue you by making you look at all of these slides here. So definition, we already talked about the ICAO definition there. But this definition actually came from an FAA safety brochure. Here's the medical dictionary definition and the dangers associated with that. Basically, we know fatigue is attributed to accidents. The first fatigue-related accident, the NTSB said fatigue was causal, was a DC-8 flown by Khalida Air into Guantanamo Bay. And there was a series of events that happened that were clearly related to fatigue. But since then, the NTSB has attributed causal and contributory factors of fatigue into very accidents. The insidious part of fatigue, though, is we're just like being drunk, we're not really able to judge our level of fatigue or impairment independently or objectively. And I've already talked about the different types of fatigue, just briefly reviewing. Transient is brought on by acute sleep loss, sometimes called acute fatigue there. Basically, if you have 6 or less hours of sleep in a night, you're in the hole. The cumulative fatigue is over a long period of time. Anyone who thinks they can get by on 6 hours of sleep a night because they've done that for their entire life is fooling themselves. And then circadian, we'll talk about soaring and the circadian. The biggest circadian low is in the very, very early morning hours, but there's another circadian low, and that's between about 3 and 5 p.m. And we think about when we're doing a lot of our soaring flights, particularly in the summer. This is an area where our core body temperature is dropping. Melatonin levels may be going up during that period of time. And we're at higher risk for fatigue. So I want everyone to be aware that that's particularly vulnerable. It's not as bad as the one early in the morning, but it is a particularly vulnerable period of time. Our normal circadian rhythm is about 25 hours, but it's overridden by the light that we have. And exercise can also affect that as well. So circadian desynchrony, that's the medical term for jet lag. And that's basically when our hormones, our natural body clock, something from the brain sensing light called the suprachiasmatic nucleus, is out of sync with the local clock. So it affects not only our sleep, but also our memory, our thought, our reaction time. Periods of circadian low, our reaction time goes down. Our mood, our energy, but it's associated with a lot of hormonal changes, even with our ability to digest, to have bowel movements, our blood pressure. Everything is driven by this circadian rhythm here. And we have different stages of sleep. 1 and 2 are the light sleep, 3 and 4 are the deep sleep, and REM sleep is particularly important. It's when traditionally we have most of our dreams, not exclusively, but that's where when we get mental and emotional recovery. We also get solidification of learning that we've done before. During this period of time, the body is actually paralyzed. You don't have acetylcholine below your spine, which makes muscles move, which is a good thing because then we don't sleepwalk. And this is a chart of our normal sleep cycles. You can see horizontal axis is hours, vertical axis is depth of sleep. And you can see that the initial phases of sleep, we have extended periods of deep sleep and very little REM sleep represented by the red that's up there. So if you're getting 3 to 4 hours of sleep, you're getting this sensation that physically you're recovered, but mentally getting less than 6 hours of sleep, you've robbed yourself of more than half that mental recovery, the cognitive formation you have, the emotional recovery. People with PTSD after a traumatic event, we work real hard to make sure they get some REM sleep because that helps them with emotional cleaning of that event. But there's so many other things. So a personal rule of thumb for myself, even though, as a medical resident, we were on 36 off 12, which was ridiculous. I can't think of how many people I unintentionally harmed or killed because I was up and stupid, because I was so fatigued. But now my personal minimum is 7.5 hours of sleep a night to make sure I get that REM component as well. These are all factors, again, in the interest of time, I'm going to do a little more superficial review of this, but these are all factors that contribute to the quality of sleep. The one thing that I don't have on there is light. Light is the biggest driver. It will suppress melatonin, so it's good to be exposed to bright, low angle sunlight early in the morning. Daytime doesn't make a whole lot of difference. And there's some research that says low angle sunlight in the evening will help bring up those melatonin levels so that you can do that. I remember I talked about some of the exogenous factors such as alcohol, which is a sedative, very effective sedative, but it destroys REM sleep. So the cognitive benefits you get from sleep are negated by use of alcohol.
Well, I got one quick question on this.
Yep.
What are your thoughts on napping?
So I think napping is good if done strategically. Going back to that one slide we have here, I limit my naps to 20 to 40 minutes because if you nap longer than that and you have to get up, you have this sleep inertia because, I don't know, can you see the mouse moving on my screen here? You get into the deep sleep. I don't know if you can see that. But you get into stage 3 and stage 4 sleep if you go past about 40 minutes. So if you have to wake up, a nap of 20 to 40 minutes. Also, don't nap past about 3 p.m. because remember I said the cumulative time awake is what drives the adenosine levels that caffeine suppresses. So if you take a nap, you're essentially pushing your adenosine levels down too. So napping, if you need it, is good up until just after lunch, siesta time, but don't do it after that. And if you need to be awake and alert, nap for less than 40 minutes or go for at least 2 hours. But generally, if you get enough sleep at night, you don't need 2 hours during the day. Okay. Okay, yeah, we talked about a lot of those already, but these are things that interfere with the quality of sleep that you have. And remember I said PTSD, those people don't get REM sleep. That's a really difficult problem for them. Sleep apnea, I've already talked about the dangers of sleep apnea. Plea to everyone out there, if there's any question about whether you have sleep apnea or not, please go get it evaluated. You reduce your risk of heart attack, strokes, hypertension, diabetes, obesity, depression, and certainly cognitive ability, because you're spending a substantial portion of your night hypoxic, not getting the blood flow. It disturbs the sleep patterns, but most importantly, you don't get the REM sleep. So the cognitive aspect, the restorative cognitive aspect of sleep is missing in people with sleep apnea. And sleep apnea is, the stereotype is people who are overweight, but about a third of people have a normal body weight. A third of people with sleep apnea have a normal body weight. The FAA has a clear protocol for getting cleared for that. And through our office, we get dozens of pilots with sleep apnea every week cleared to go back and fly. And again, as I said earlier, the most common comment I get is, I never knew I felt so bad before until I feel so good now that I've got that. I'm just going to skip over this. These are a host of medical factors. And these are contributing factors again, that I've already covered as far as causing fatigue here. Helicopter pilots with the vibration and turbulence are notorious for fatiguing out quickly because of the noise and vibration they get for there. So there are a lot of studies about fatigue. We know some things and we don't know some things. But here's the scary part. What we don't know is how long it takes to recover after sleep deprivation. Okay? Several very good studies have shown that time in bed, TIB, for 10 hours after sleep deprivation, when these people, the studies varied a little bit, but generally they had 5 hours of sleep for several days beforehand. But we know that 3 days is not enough, and we have a fairly good indication that 5 days is not enough to recover from acute severe sleep deprivation. There was one study that showed after 7 days of recovery, when you had 8 hours of time in bed, you could make up, and these were looking at cognitive performance on tests. So I pointed out fatigue earlier in the slide when we were talking about the I'm safe type checklist. Again, these are aviation specific studies that looked at what factors that are significant for aviation safety. And John Caldwell, who did the first research on this, and he's probably the world's premier researcher. And at the end, Drew Dawson is in University of New South Wales. John Caldwell's an American, but these guys are just brilliant sleep researchers in an aviation context. I'm getting repetitive here, so I must have been fatigued when I did this. Okay, and these are, again, some of the things I've already pointed out, but missing the last few seconds, the lights on, but no one's home type thing. That's the micro sleeps where the brain grabs a small nap, anywhere from 2 to 10 seconds, where you see the EEG change and the person's EEG goes into a sleep pattern, yet their eyes can be awake and they can still be functioning, doing automated behavior, such as driving down a highway at night or flying an airplane. And I would wager that some of us on this call have fallen asleep while we were flying solo, even if it was just a micro sleep. So the micro sleeps really are, I said in this case, they can last up to 30 seconds. That would be an extraordinarily long. Usually they're in the neighborhood of 2 to about 10 seconds. But again, the EEG changes, and generally you're not aware that you're doing. There's one video I show of an individual who was driving a car for 2 hours after 3 days of sleep deprivation, 3 hours a night. And he was actually driving a car around obstacle courses, making some mistakes. But in the 2 hours of driving, he was asleep by EEG for 23 of those minutes, but continued to drive. Not very well, though. So mitigation strategies to avoid fatigue. Make sure you get some sleep, usually at least 2 nights beforehand. Don't take medications that impair your alertness, such as the over-the-counter antihistamines or nighttime medicines. I've already told you that alcohol destroys your REM sleep. If you can minimize your pre-flight physical exertion, so on a hot day, pushing your glider up a hill for a long distance, wait for the golf cart to tow you out if you can, or get someone to help you. Use the sunglasses so you don't get that glare and the fatigue that comes with the brightness. Reduce your heat exposure, because again, heat is a fatiguing and dehydrating type thing. It can be very effective with neck cooling. I know some people in our club use the kind of like the plastic peanuts that you saturate and put in a neck gaiter that you have. I put them in the freezer and then it cools you during the day. Or I've sometimes gone to using a washcloth or a cleaning thing that I have and putting my drinking water on it and putting it on my head just to increase that and putting my hat over top of that. Okay. And as I said, smoking increases carbon monoxide, decreases oxygen saturation, makes you hypoxic, and increases your fatigue. So another reason not to smoke in addition to all the cancer and heart disease things. So another fatigue mitigation, we talked about caffeine earlier. Strategic use takes about a half hour to kick in. So if you're caffeine dependent, that's probably not an issue. You just want to make sure you have caffeine available to you when you're flying. So caffeinated gum works extremely well. And that would probably be my thing of choice, although some of the sports gels and the sports little blocks that they have will have up to 75 milligrams of caffeine. Typical cup of coffee, not the Starbucks double latte, whatever the hell it is, will have about 60 to 70. Soft drinks, caffeinated soft drinks have about 40 to 60 in there. Some of the monster drinks have 200. But if you're getting in more than 300 to 400 milligrams of caffeine a day, you're probably dependent and should have some caffeine available to you during the flight if it's going to be a long flight. If you're not caffeine dependent, caffeine ingested during the flight will increase your alertness. We talked about eating small continuous infusion. That's why I like those sticks of the mozzarella string cheese sticks, because they're not messy. I can get them in small amounts continuous. They have complex carbohydrates plus protein in them. And some of the protein bars are like that. Make sure you get plenty of hydration in there. The sports drinks with electrolytes are good, but you can get the electrolytes through food that you're eating as well. And then also to avoid fatigue, you got make sure the cockpit is comfortable for you when you're going up, because there's nothing more irritating than a hot spot in your seat or a buckle that's binding somewhere like that. So make sure that you've done everything you can to optimize that. Those of us who own our own aircraft have tweaked them over the years to make sure they're as comfortable as possible. And then also I want to emphasize having a relief system that you're willing and able to use on a regular basis so that you stay hydrated. Again, my hydration strategy is when I'm flying, I carry 6 liters of drinking water, and I use a relief system that it connects into a Camelback, and I can usually fill a 2-liter Camelback at the end of my flight, and I feel good about that. Other things as far as the oxygen system, you can use a higher oxygen setting. So you do that. If you are feeling fatigue, start monitoring the radios, make a call, just start interacting with people, increase your level of alertness. Remember, you have a window of circadian low in the late afternoon. The question about napping, I've already talked about 20 to 40 minutes strategic nap. I know when we were at the World Championships, a number of the pilots before they took off would just lay down under the wing and take about a 20-minute nap, which is extremely effective, both for physical, but also for cognitive rejuvenation on that. In a glider, it's a little difficult to prevent deep venous thrombosis because we don't have much of a chance to stretch, but flexing your ankles is a good strategy, or frequently wearing compression socks also will help. Caffeine we talked about. Melatonin, let's kind of skip over that other than the paradoxical effect. There are about 10% of people who take melatonin and be wide awake, irritated. Sleep aids we're not going to talk about because I don't think that's relevant in this situation, but I do want to talk about, again, emphasize diphenhydramine, Benadryl, NyQuil, Tylenol, PM. They all have the same thing in there. Cause a hangover, cognitive impairment, 60-hour restrictions from the FAA. A lot of people will take, particularly college students, will take ADHD medicines. They're not legal to take from the FAA because they're amphetamines. They will increase your alertness, but they can cause dependence. come down the home stretch here. Also to avoid fatigue, make sure you do your flight planning the day before and then update it in the morning so you're not time pressured to do things and stressed early in the morning. You have adequate crew to help you push out the airplane. If you're always using the checklist, and again, not only the aircraft checklist, but your personal checklist doing the I'm safe. If you can, pre-assemble the glider beforehand to save the physical load, get it out early in the morning. Stay in a shaded area so you can be cool. And I know I'm beating a drum here, but have a release system and stay hydrated. So here are some resources regarding fatigue countermeasures that you can do. These are all really good publications that we have that will help you. Again, John Caldwell wrote the article in Aviation, Space, and Environmental Medicine about that, which was good. So to summarize, we're human. Despite being pilots, we're still human. So it's impossible to fool our physiology. But you can maximize physiology by taking advantage of eating, sleeping, different substances you have, different strategies, shield. Pharmacology can help you, particularly caffeine in that, but pharmacology can also hurt you too, such as alcohol or Benadryl, diphenhydramine. If you plan ahead of time using checklist, plan your flight, you're going to improve your performance, reduce your stress, reduce the cognitive and physiological load that you have on there. And then, of course, preventing any of these things that I've discussed today is the best strategy. And I think I've given you good strategies. I hope I've given you good strategies to try to prevent that. So I know it's late at night. It's 11 o'clock at night almost on the East Coast. I hope no one's going to be flying early in the morning before they get their 8 hours of sleep. So there we go. Let's land out. And there's the last minute closeouts to make sure that you do everything you can to make yourself the best possible physiologic and cognitive specimen to go out and operate safely and efficiently. So Brandon, with that, I'm happy to take questions. I'll be happy to stay around as long as you want to and other people have questions.
Most of it we've answered live or that I answered just one-on-one and put it in the chat. A lot of comments saying that you did a great job, and I agree with that. I do have one leftover question from about an hour and 10 minutes ago, and that was regarding sunglasses. What's your recommendation on the photochromatic, the light-sensitive sunglasses?
I have mixed feelings about that. I like the feature that as the light changes, it adapts to that. So that problem that I get if I'm flying west at it may increase the shielding that I get, but there are two potential problems. One, they depend on UV light, and a lot of times the cockpit will shield that UV light, and you won't get the change that you're expecting to get. And the other thing is, if you are getting the change, depending on the amount of the UV light that's triggering that, it doesn't change quickly. So if you're going from clouds to bright light, you may find yourself in a situation where it doesn't get dark quick enough, or the contrapositive of that, if you're going to, from bright light into clouds and you have dark sunglasses, all of a sudden everything gets real dark and you can't see. So generally, if you look at that FAA handbook, it's probably not a good idea while you're flying. It's a better idea while you're on the ground.
Okay, thank you. We don't have any more questions in the queue. So
Okay.
let's wrap it up. We're at 119 minutes. So I think you did a great job. Thank you.
You're most welcome. Let's see. I stop my screen share. I'm trying to figure out how to do that. I want to go back to the. Can you stop me from sharing my screen so you can put the display on? I clicked on the new share. Oh, well, if we can't, I'll get out of that. All right, well, thank you very much, Brandon. I appreciate it. And to Dave Raleigh and Frank Wiley, thank you very much for putting this on, and Dave for the entire series that you're putting on every 2 weeks. I think it does a wonderful job in helping people be smarter and safer cross-country pilots. So thank you for that, Dave. It's a lot of effort, and we truly appreciate it.
Oh, we appreciate that. For everybody, we have modern speed to fly is our next topic, and that'll be in 2 weeks. So
Okay.
7 o'clock on Friday in 2 weeks.
Okay, and we also get wings credit for this too, if you're registered on FAAsafety.gov. So use this to help complete your next phase of wings.
So I think we're done for the evening.
All right. Well, thank you very much all for listening to me. And thank you, Brandon, for fielding all the questions and setting things up. I appreciate it. We'll see you at the airfield tomorrow, I hope.
Yeah, hopefully I'll see you tomorrow.
All right. Thanks a lot.
Don't forget to PDF the slides.
Yeah,
All right,
I'll be happy to PDF it and send it to you, Frank.
yes.
Okay, you got it.
All
How
right.
long until this recording is up on SAA website?
Within a day to 3 days, it depends whether getting it on the YouTube channel sometimes requires 2-factor authentication. So I
Okay.
have to contact somebody else to complete that code. But other than that, it should be up tomorrow.
Plus, it's the weekend.
Okay?
Awesome. Thank you so much. Talk to you guys later.
Okay, thanks a lot.
All right. Bye-bye.
I don't.